Tonight, we have a guest on who's been here many times before, going through a lot of technical issues and the scientific aspects of many questions. But the fundamental question that nobody's been answering is, how do I navigate through the world of psychiatry? Where do I start? How do I get the right services, one, for old people like me, but two, more importantly and harder to discern is pediatric psychiatry. Where do I start? So why don't we start with introductions?
Sure. I'm Dr. Levine. I am from the Boston area right now. Used to work in Milford, and that's how we met many years ago when I was working for Tri-County Medical Associates. I started the child psychiatry program with the Tri-County Medical Associates and left in 2015, so was there from 2011 to 2015.
Now, John, how do I know that I could benefit from psychiatric services?
Well, how do you know that you could benefit from psychiatric services? Specify your question more.
Why would somebody come to you? For either themselves or their child?
So it's a good question, and one that is hard for people to answer. A lot of times, people should. Let me start with people should come for services because they're concerned about something going on with a relative or themselves. If you have any questions about your safety, that's probably the most important reason to seek out psychiatric help. If you have questions about use of substances, that's a time when you ought to seek out help and go to a psychiatrist. You can seek any help from any one of the mental health professions, and that's something we can talk about. There's a vast array of variants on specialists in mental health. Social workers, psychologists, psychiatrists are the three main types. But the times I would think you really should be seeing a psychiatrist and getting consultation or one of the other professions is for safety, is for a change in mental status that you would say, your relative, or if you're aware, you're not functioning like yourself. And third, as I said, substance abuse. When you know that you're overusing a toxic substance, street substance, a non-prescribed substance, alcohol.
Or today, opioids.
Or opioids is the big one today, is a huge national epidemic. In the early 2000s, it was methamphetamine. It went on, it became cocaine for a while, but right now, because of I don't know much about
the
reasons.
Problem that a lot of us face is when we think of, when we grew up, the stereotype drug dealer. You think of a shady alley in the inner city, kind of a scuzzy character. You don't think of the teenager next door.
Right.
Somebody you grew up with who cut your lawn, who babysat. It's breaking all the stereotypical molds that made it easier for us to say, well, that's somebody else. It can't really affect me.
Yes, it's worked its way into mainstream
Americana,
yes.
we start thinking of how many issues we've had in a little town of Milford.
Yeah.
And Milford's 28,000 people.
Yeah.
It's not that big, but yet, without Narcan.
Yeah. When I was here, even in last I was here in 2015, there were many admissions to the emergency room. I think the ED doctors were telling me at that point there were deaths almost on a daily basis.
It's amazing.
And these, as you say, were not people from another side of the town or the bad part of town. They were regular folks living in some of the more affluent areas.
Well, it was easier to rationalize it when it was them. And I don't think them had a color, had a religion. It was just not us.
Right.
And then all of a sudden, you realize it's the kid next door, the girl who hurt her knee playing soccer. It's a scary movie to some, old people like me, because you just don't know how do you even deal with it.
Well, when you think about substance abuse, the rates are increasing in some areas. There are some areas that are decreasing. Alcohol use has actually decreased in teenagers. Marijuana use has increased. If you look at when the onset of substance abuse really begins, it's probably in the early high school, when it becomes sort of an epidemic problem. It's in the late high school years. Generally, for people who are going to have problems, it can be identified in the early high school years, even in middle school now. But some substance use has decreased. As I said, tobacco is way down. We can think about what things have helped with using tobacco and as a model for intervening. Go ahead.
I was going to say, a lot of that, though, is inconvenient because you can't smoke in any buildings.
Right, but limits were set, and maybe that's a model for...
And when you think about it, they started the kids early. I mean, it was funny because I was with a good friend one day at his house, and I kept laughing because we wanted to have a cigar. So we slithered out the back. We kept looking over our shoulders saying, are we far enough away that they won't see us? We got far enough away, we sat down and fired up 2 Cohibas we had brought back, nice Cuban cigars. It had been the first time in 6 months. And I looked at him, I said, what's ironic is your neighbors could look out the door, see 2 men hanging out on the street, call the cops, and how are we going to explain that? No officer, we're just trying to sneak away from our kids so they wouldn't see us having a cigar. But
so it is a matter of now you're an outcast. It's become countercultural almost to
But it wasn't even that. The last thing I wanted to do.
Yeah.
Okay, so this had been 6 months, but I don't want to have my daughters seeing me when they were small smoking.
Right.
So it became that whole pressure, not only of the regulatory constraints, because I do believe that.
Well, there was a social.
There's a social piece.
There's an increased awareness of there's an educational factor that people now, back in the 50s, people didn't even know that cigarettes cause cancer. It wasn't known. People were smoking, and it was considered very acceptable.
You're having a cup of coffee. I am hooked on alkaloids. There's no question. I love my caffeine. Okay.
But it's not. That's not causing you any problems. In fact, the latest research on caffeine is it's probably a net plus.
But now, we have 3 different types of mental health care professionals.
Yeah.
Explain me. I got a social worker, a psychologist, and then a psychiatrist. Now, the psychiatrist I can understand. That's a full-blown MD.
Right.
What are the other 2?
So a psychologist is someone who has a doctorate degree. Not necessarily, can have a master's degree as well, but they did a advanced graduate work in psychology. They went on beyond their master's degree to study psychology. Usually, to use the term psychologist in Massachusetts, you actually have to be a PhD and have a license. So there is a professional licensing division of Massachusetts that licenses psychologists and licenses social workers. You have to have a PhD to be licensed, and you actually, there's a law that says you can't say
So
you're
you
a
can't just
psychologist.
graduate with a bachelor's in,
Say you're a psychologist.
Right.
You can't even use the term technically psychologist unless you've had not just a PhD, but a license.
Special training.
You have to pass that state license and be certified. So those people have this graduate degree, the PhD, and their specialty is the thing that psychologists can do that sort of no one in the mental health field can do except for them is the psychological testing. So if you need an evaluation that would involve IQ testing or neuropsychological testing, measurement in an objective way of psychological functioning, not brain function, but behavior. But in a quantitative way, a psychologist would be the best person to go to. What would you do with that information? Hopefully you would be going to the kind of psychologist that would be testing you for information and giving you feedback on information that's going to help you proceed. So if we go back to your first question, when should you see a psychiatrist? When should you see any mental health professional? The three things I mentioned: safety, you're feeling a change in your mental status, or you're noticing a change in mental status. I mean, we call it altered mental status. It's thinking that is so atypical. It's an obvious. It's like a psychotic person who they're having hallucinations.
so if I'm normally an upbeat person and I start feeling depressed all the time,
yeah,
that would be a trigger to say,
there's a question on that one. So I would divide the disorders into three categories: depression and anxiety. And you know, if you look up in the ICD-10 manual, or which we code all our diagnoses under, in medicine and in psychiatry, you'd have 300, 500 diagnoses, you know, eating disorders. But in general, you could probably do well by separating out all of our diagnoses into three main clusters. One is anxiety and depression. Two are psychoses and other disorders that affect cognitive functioning and are true changes in reality testing. So someone doesn't have an awareness that they're in this room, they think they're somewhere else. They think there's poison in the room when there is not poison in the room. That's a psychotic disorder. So I put anxiety and depression, psychosis as a mental status change. I wouldn't necessarily say anxiety and depression we can so easily define. And then I'd say substance abuse is one that is very hard for you to recognize as the person. The denial is the number
no,
one.
but the family and everybody can see it.
You can see it. It's also a little tricky, but I think it's significantly separate. The problem with separating substance abuse from the other two diagnoses, a psychotic disorder or a disorder of reality, well, let's call it a disorder of reality testing. So we can all agree that you're telling me that your wife is poisoning you.
Don't give my wife any ideas.
and she's not.
Right.
You know, and you've never thought she had, and you woke up one morning and said, why did you put poison in my food? You probably have developed some kind of an altered state, and that's very clear. If you said, I'm feeling a little low, I'm feeling a little depressed, it's sort of harder to find the line to divide that. But nonetheless, severe depression has the huge risk of suicide. So that's where you get into safety in both ends. A psychotic person who's hearing voices that are telling them to kill someone, and that I should make a caveat there that the majority of psychotic people are not violent. Something like 5% or less than 5% of people so we should not think psychosis violence, but there is a risk and a higher risk of an act toward oneself. If they're hearing voices that say kill yourself, you're worthless, there's a risk.
There's more risk to the patient themselves than to the people around them.
So we have three, so when I said before, when should you go to a psychiatrist, safety is the number one reason. Depression can cause a safety risk, a lethal risk. Just like, why do you go to a doctor? Essentially, because could this progress to something that could cause
But now, John,
you
when
to
I
die?
think about it, as social worker,
Yeah,
psychologist, psychiatrist, you invested more than half your life in studies
yeah.
to go above and when would is it a progressive thing? Kind of like I go to my primary care physician, he kicks me to a specialist, they kick me to a surgeon. I mean, how does that work?
Is a psychiatrist sort of a higher level degree? I think some psychiatrists think that's so. We do train for a longer number of years. Psychologists train probably 5 years beyond their undergraduate degree. Medical school is only 4 years, but there's 4 years of residency, 4 years of fellowship, and then usually 2 years of subspecialty. So you're
That's
talking
14 years.
Yeah,
To
beyond.
say that's half your life.
Yeah, you don't really end up, most people don't end up practicing medicine, psychiatry, or whatever until their early 30s to mid 30s. So, you know, you've gone from 22 to 33 very fast.
Taking a
without
decade out of your
It
work.
takes a decade out of your life, yeah. So in some ways, the education itself is so consuming that you feel you have more knowledge as a psychiatrist. But nonetheless, psychologists would put themselves up against any psychiatrist saying, I'm as skilled.
Is that right?
Oh, yeah, yeah. No one in the mental health field feels that, no psychologist would say they have less skill in what they do because they test and they do therapy. They don't prescribe medicines. That's the one thing only MDs do, and medicines are a very important part of treatment. Interestingly, for going back to our discussion about opioids, you know, the norm for alcohol treatment is abstinence, right? It's going to AA and stopping. The norm for opioid treatment is actually prescribing medicine. There are 3 medicines for opioids. One is methadone, 2 is Suboxone, which is buprenorphine, and the 3rd one is Vivitrol or naltrexone. Those medicines are considered the treatment of choice, the practice parameters across the country.
You never hear that. I mean, the only thing you ever hear is Narcan.
Yeah,
You know, people-
Narcan is for emergencies, yes.
People
Rescue.
forget that, you know, things like heroin are very efficient respiratory inhibitors.
Yes, right.
I mean, I remember one time when I messed up my knee, I was in the emergency room and they gave me morphine, they wouldn't let me go home. Because they said, it is a respiratory, you could stop breathing.
Right.
And if you do,
You have to
we
find-
want you
You
here.
have to find the right dose.
So,
before
you know,
you
the
go out.
Narcan is what you hear about, but that's really bringing you back from the edge.
Yeah, when someone is at a, you don't want to give Narcan to somebody who's got, is using a little heroin because you might put them into acute withdrawal, which would be, I mean, it would be better than them dying of an overdose, but respiratory depression, it would reverse respiratory depression,
Right.
but might easily induce an
But you know,
overdose.
you're right, because you
withdrawal.
turn around and say, if the option is door number 1, death, it doesn't really matter what you do on door number 2. It's
Yeah.
better than number 1.
Right.
But if door number 1 is still closed,
But you have to know that if somebody's coming in on a, you know, and there's someone intoxicated on heroin, and you give them Narcan, you could put them into acute withdrawal, which is not necessary if they're not, and only a, you know, in that level you're dealing with an emergency room physician or a critical care physician, not a psychiatrist who's going to manage an
So
actual
again,
overdose.
I am kind of still stuck on my family. Somebody tells me something's wrong, you should go talk to somebody.
Right.
When would I talk to a social worker?
You would talk with a social worker as you would talk with a psychiatrist, as you would talk with a psychologist, all three of the main professions in mental health, for therapy. And it could be group therapy, it could be couples therapy, it could be individual therapy, but it would be for the benefit of sitting down with someone and saying, I'm having some difficulty. Having the ability to do that is very important. A psychotic person probably wouldn't go to a social worker for therapy because they're needing medicine to bring them back from
Sure.
state
But then
of
that's a
unreality.
physical issue.
Well, that's, yeah, and it is, absolutely, it's a physical condition.
If you have an imbalance, then medicine or...
It's much more obvious when someone has lost touch. But it's also not it's probably the minority of the issues that people go to mental health professionals for. So social workers, psychologists, psychiatrists who do therapy and don't do medication primarily as the main intervention are treating people who have anxiety, depression, potentially someone with a psychotic illness who's been treated with medicine but needs reintegration into the community.
So if I'm talking to my primary care physician, because I assume I got to get referred.
You
or-
actually probably don't need a referral from your primary care now for mental health. That's, I think, part of the new, the ACA, Affordable Care Act. And in general, you haven't needed referrals for, it's not a specialty that you need a referral for. So it's because of the confidentiality of it if you don't want to go to your primary care. It's a very good way, I would highly recommend that people go through their primary care for a referral, because they can screen out people who may not be the best person for you to see, may not have a specialty. It's a funny field in that there are a lot of different disciplines. It's not just MDs who are, you know, for example, in the rest of medicine, I don't think there is a kind of hierarchy where the MD kind of is you would assume the pediatrician is above in
Right.
some way the nurse practitioner, even though they're equally qualified to do, but they were supervised. If you really
Well,
had
it's
a
a
tough
lot-
foot, but in mental health, it's more
It's a lot
it's
cleaner
much
when
more
I think
lateral.
of, I have ocular issues.
Yeah,
So I have an optometrist,
right,
and they can do a lot more, but they're not prescribing medicine.
right.
I have
And
to
they're
go to
not doing
ophthalmic,
surgery,
and
and
I have to go to an ophthalmic surgeon.
Right.
It's like when my cataracts started failing
Right.
or growing, my optometrist sent me to an ophthalmic surgeon, and he did the surgery. That was clean. I can understand that.
Yeah, there's what you do in psychiatry in general is not as definable, as not as clear cut as what other physicians do. In some
Yeah.
reasons, that's why psychiatrists are sometimes thought of as not real doctors.
But it's worse. I mean, I always was amazed when I was down at NIH, the MUD-FUDs, the MD PhDs. I sat there and said, oh my God, these people have dedicated not only the time to become a full-blown MD,
Right.
but then a PhD or vice versa.
Yeah, yeah. And
The psychiatrist, you're even going 4 years beyond them.
yeah, no, well, I would say a PhD MD's probably done more. You know, psychiatrist doesn't have to be, I have a PhD as well, but you don't have to have a PhD. You can
Right.
have just an MD and but it's still 14 years.
That's the first time I've ever heard somebody say just an MD. You know, it takes a MUD-FUD, it takes somebody with both
Yeah.
to sit there and say, well, if you only had an MD.
Yeah, it was, I happen to have an interest in research, as you know, so my first pursuit was a PhD, and then I did my MD. And there are a lot of
Well, I've
folks who are
seen it
doing
where
that. but-
people want to get into the medicinal side, but then realize their heart is in the cutting edge research.
Yes, yes.
And I saw Building 10 down at NIH was full of people, one way like you, who did one then the other, or the other.
I've always done a mix of both, and to my detriment in some ways, because those who find one is satisfactory can sometimes do, focus is important, you know. I love my work because it does involve investigation. I can't imagine for myself, but you know, we can talk
So
about
how
me.
would I ever get to you? I mean, realistically, something's changed. My
Right.
family, my friends have suggested I go to my primary care, or I find out how to get to a social worker, and now they say, we want you to talk to somebody more specialized. Psychologist, psychiatrist, how do I, tomato, tomato, how do I figure out which one?
I think I think that for a while, psychologists thought of themselves as the next step up from social work, and I think they still probably do because of they've had more years of training. You know, in fact, more years of training doesn't make you a better psychiatrist because it's a very interpersonal, human interaction, probably the most of all the medical specialties or healthcare specialties, right? I mean,
It's also the least defined.
it is the least defined.
I mean,
you
I
know,
hate to say it, but
what are you doing?
my ACL was torn.
Right.
Okay, I can put a wrapper around that. You know,
Yeah.
I can go down and Michael can look at it and say, this is the options you have.
It is a very, it's a fascinating area. I've loved working in this field for many, many years, 30 years now. But it still is obvious that we're far from understanding the brain and the mind and how they connect at the level that we understand the ACL tear or the fractured
When
arm.
I was at Holy Cross, I took a psychology course. It convinced me never to go to that side of campus again. Because I remember, I mean, in the science wing, A plus B equals C.
Yeah.
One took a psychology course. Well, unless B had a bad childhood, or A was involved in environmental factors.
Right.
And I remember asking the professor, what's the right answer? And it was, there is no right answer.
Yeah.
The variables are so
They
complex.
already are in undergraduate, we're starting with a lot of gray. There's a group of psychiatrists like myself who work in the tertiary care hospitals who are very interested in finding sort of the scientific underpinnings of mental distress, mental illness, and we've made some progress. That progress, you know, its translation to the clinical realm where you have a problem today, we are so far from that point that we've got a whole group of people at MGH and where I work, and NIH.
That little
you mentioned-
university called Harvard.
Yes, the main campus at Harvard, the neurobiologists are doing tremendous work. They're working on, the most interesting questions, but because the brain is so complicated, it is probably, and I think most people would agree, in the brain-mind connection. So your mind is an emergence of your brain function, but it can never be sort of grasped. So it's while we understand many things we didn't 10 years ago, I think it was in the 90s that Bush declared this was going to be the decade of the brain. And in this 10 years, we're going to figure out mental illness. We're going to focus on it, and I believe dementia was thrown in there. But we're 20 years later, and we are far advanced from where we were, but we are not close to being ready for prime time. So we're left with great data, great science, and this person who comes to your office that you can't use any of that for. In most of the other areas of medicine, once you sort of travel down a certain, even in cancer research, which is still a very primitive field in terms of curing cancer relative to other things like a ACL tear, they can translate research findings right now, give you a drug. A drug is made based on research that's been done. In psychiatry, we have drugs and medicines, but they're not, they're not based on the research that's being
Well,
done.
but again, it's so gray. When I think of oncology, very simple. Chemotherapy is an oncologist trying to kill the cancer a little bit faster than he kills the patient. So if I want to measure success, I'm still alive.
Yeah,
You know, my mother had intestinal cancer 12 years ago. Treated by Monocatus, 12 years, she's still here.
right.
I can say, check, that's a good thing. I'm depressed. Why?
And how do you know when you're better is the thing.
Well, that's-
I think what you're saying is, how do you know your cancer patient is survived? That's your ultimate
I'm above
measurement.
ground, I know the oncologist did their job.
Now, in psychiatry, as I said, the most important reason to see a psychiatrist is to prevent a violent or self-inflicted lethal event or substance abuse, to prevent a death, as you said, from heroin. So we can measure, are people still alive?
But the substance abuse, I can understand. You know, I can get my own, whatever the reason.
You see it, they're drinking, and there's a
They're
certain
drinking
amount
too
of
much,
drinking.
they're ingesting oxy, they're doing something.
Yeah.
They're injecting heroin.
It's physical.
It's physical.
Yeah.
I can understand. How you got there, different debate.
Right.
But you're there. And obviously success is
so that
you stop.
Right, right.
But when I take your first case,
So we do try to have, so you're asking a number of really important questions. We could probably go for another hour on this, because it's just so much to talk about in terms of what are we doing in mental health, how have we progressed, who do you see, how do you know who you're getting better, how do you define success? There's so many critical issues here, and maybe we should, even revisit this at some point. But we do try to objectify even depression. So for example, if someone isn't getting out of bed, and they typically get out of bed, they're not paralyzed. They have no reason not to get out of bed, and they're suddenly sleeping all day. That could be that they have sleeping sickness. It could be that they have an organic basis for it, but it could also be that they're depressed. So if it turns out that we can pretty much put when did the person start to feel sad, because that's very subjective, with when did they not get out of the room, or when did they sleep excessively, or when did they start gaining weight in a way they never
see,
did
again,
before.
those are physical things. When you sit there and
Well,
say,
that's what I'm saying. It's
I'm not getting out of bed. I can see it, I can
Yes.
feel it, I can touch it.
right, and that's why I think we do try to objectify as much as possible these more subjective disorders that we have in psychiatry. So sleep, appetite, energy. How do you define energy? If I ask you, is your energy okay? That's not a very objective answer. But if I said, what do how tired are you by 10 in the morning? And you say, I'm just feeling so weak, and everything else has been ruled out. It can be a depression. Cognitive function can change with depression. Your memory is less, your concentration is less astute.
But wait a minute, my family tells me there's been a change in behavior.
Mm-hmm.
I think I'm fine.
Yeah, and that's usually a sign that something is wrong. The more serious the problem, the less likely the person will recognize it.
Because I'm going to say, not everybody can be wrong around me.
Yes.
If
Right.
my darling bride thinks I got a problem, she's probably right, but I can disagree with her.
Right, you can.
If my children and my wife
Right.
and the family all say, hey, something just isn't right with you anymore. You're not happy, chipper, whatever, you're just going through the motions. Okay, first of all, I got to accept the fact, and that's got to be hard.
Well, you have to put in consideration that let's allow for a certain degree of subjectivity. That what you call doing well, and I call doing well, and in my family and your family, there's natural, cultural, familial norms about what's doing well. You know, some people in some homes, the level for which you have to take action and do something is different. But at some point, I think everyone can agree, or at least we think that most people can agree, this person is just not right. And I think we have to use that measure that, as you said, a large collective group, not just the family, but the primary care doctor, the teacher if it's a kid, the employer if it's you know, somebody
But how do you establish a baseline? I come in.
That's a great question.
Terrific
Terrific
I come
question.
in
Yes.
and something's not right. Okay, so you've now known me for 3.5 minutes.
Exactly.
And I say, what's wrong with me and how do you fix it? Everybody around me tells me something's not right. Where do you even start?
It's a very, very important question because almost all of healthcare right now is working on getting a person back to baseline, right? So when you come into the hospital, we want you to leave the hospital at as close to the norm that you had before the event that brought you into the hospital occurred. So we want your leg as good, your ACL as close as it was to normal. But in psychiatry, people have more long-term issues. So when they come to see someone, they're raised above what is normal for them. So you know, he's kind of a down guy. He's an introverted.
He's
not
always
very
been
social.
He's always been Eeyore.
He's glass half empty for him. Always.
Right.
That's his personality.
How would you know if he was depressed?
Exactly. But you would, in the sense that if he's not getting out of bed, if he's not eating, if he's losing weight, if he's not socializing even to the level
that he used to,
you know, with Tigger, you know, the normal functions have significantly changed, and usually we would say there's a safety concern of some level. So I personally wouldn't say that being depressed is a medical condition in and of itself.
But then what do besides, I don't want to say drug abuse, but substance.
But just to go back to I want to be clear. I believe major depressive disorder exists and is a medical condition.
Well, clinical depression, nobody's going to.
Right, but that's where it gets very tricky, because clinical depression, you use the word clinical depression, and everybody sort of seems to know what clinical depression is. But it is a very gray line between what I would say is, you know, are you depressed? You seemed irritable, you seemed on edge, you seem not yourself, you seem sad. That's, you know, to the point where I can say, you know, you're not getting out of bed, and you've got all these other, what we call vegetative signs, physical signs of depression that go with it. The energy, the sleep, the concentration.
Those you can focus on.
Yes.
I've got to get you to a point.
So that's kind of clinical depression. But then you've got this big
gray
area where people are saying, you know, I want to get this guy some help. He just seems so sad. And I don't think that's necessarily something we can define as a medical condition as much as a judgment. There is a subjective judgment that
They may be just fine. I mean, somebody may look at my darling bride and say, you've got to be out of your mind. You've been married to him for 100 years. Why would you put up with him for this long? Well, thank God she did. But, you know, all kidding aside, when I try and say, well, I don't think he's right, he should be happier, cheerier.
Right.
Well, first of all,
who
gave me the right to make that judgment?
That's right.
They may be, Eeyore is perfectly happy being Eeyore.
Right. And that's why you get into function as the major, in psychiatry, we've sort of fallen back to, as in some of the other fields of medicine, like in rehab medicine, function is considered the criteria. So can you, but again, you know the baseline. So if a person had a fall, broke a leg, they need to walk.
I was walking.
You
Make
know,
me
now I
walk
can't
again.
walk. It's can you function and leave? You know, your leg might feel fine, but you can't walk 100 steps, and we want you to walk 100 steps before you leave. In psychiatry, what's the functional impairment? And if there is a significant functional impairment, is that my judgment of your functional impairment, or is it my judgment of my functional impairment? But someone can say, you used to hold a job, you used to be a productive citizen, you used to contribute to your social network in some
That
way.
again to me feels more black and white. There is an
This is
event.
what you did,
Yeah, and now,
you're not doing it.
You can't work anymore. You don't. Yes.
And I think that's when you can say, you know, that someone is in a depressed state that now, and should try treatment. We're not always successful in our treatments, as in all of medicine. So we are not always
What
successful.
kind of treatments are available? I mean, I can understand chemical if I have an imbalance.
Yeah.
You try and balance, you know, lithium or whatever and put me back. But
Right.
barring that, where do you start?
Well, there are established treatments for the three disorders we talked about: the depression, anxieties, the psychotic disorders, the disorders of poor reality testing, and substance abuse. So treatment for substance abuse currently is abstinence. For going to AA is as good as anything.
Or weaning like methadone to bring you
Methadone is
down.
weaning, but actually the latest data on opioid treatment is maintenance.
Really?
And keeping people on opioid substitution for up to 2 years.
Wow.
Yeah. And so buprenorphine, Suboxone, and methadone is the practice standard now for
Then
addiction
how do you
medicine.
get me off? I mean,
You
2
may,
years.
you know, if you're not functionally impaired and you're taking methadone, you're not using street drugs, you're not getting HIV, you're not injecting, you're not out there.
You may just
you
keep
know,
me on it?
I might just keep you on it. Yeah. But I have to make sure I'm the only one prescribing. You're not taking that methadone and selling it. You're not, and it's very hard to know that because but I would say that there's a very large group of people who go on methadone maintenance or go on Suboxone treatment who are really wanting help with this, are willing to commit to it. You know, you don't get as good a high from methadone or Suboxone, even though they're opiate substitutes. You don't get the same pleasure that you do from
Oxy or
heroin.
heroin.
Heroin's more pleasurable because it's a direct, bypass the liver. But yeah, you don't get the same pleasure from these substitute drugs. So the people who are really struggling actually struggle to stay on methadone. So if you can get someone to stay on methadone and not use heroin, or get them to not use one of the other direct.
See, but that's my ignorance, because I always thought the methadone
was a taper.
was a taper.
The goal is to taper eventually, but there are people who stay on the methadone for long periods of time, and then it becomes sort of a judgment call. You know, you've had 14 relapses, and every time we take you off the methadone, you're out in the street, you're getting arrested, stealing.
So better to keep you at methadone and let
it was a less of two evils, and the person is being responsible with the methadone. That's the question. If they are, and again, we go back to function. If they're functioning, they take this every day, it's reasonable. You can't take heroin every day and function. If you take heroin, you need more and more and more, so it isn't the same thing as an opiate substitute to take a methadone or a Suboxone. Suboxone, a partial agonist. Methadone is a full agonist.
Full agonist.
So Suboxone is harder to stay on than methadone because Suboxone has I wouldn't say it's a partial, but it's less potency than methadone. So it hits different opioid receptors. Because there's a delta, a mu, and a kappa opioid receptor. Heroin hits all of them.
All of them at
One of
once.
them is really pleasurable. Methadone touches it a little more than Suboxone, touches it a little less, the pleasure center. They all give you some amplification of it. There is one treatment, naloxone or Vivitrol, which is an injectable drug that actually blocks the
Blocks
area.
it.
And that's, if you really want to commit to, I can't get pleasure from anything.
This is going to be hardcore.
Yeah, and people do it, and people are successful, but clearly the treatment of,
No more dopamine, no more.
yeah, well, I mean, you can get pleasure outside of the opioid system, but that's a pretty big system to block.
I was going to say.
You know? So that's a more scientific discussion I think than we're having, is just about what do you do for people in treatment? How do you, so we have substance abuse treatment, it's methadone or opioid substitution. It's called MAT, medication assisted therapy. So
If you look at-
that's the current state of the art for that. For psychosis, it would be antipsychotics. That's the treatment. If I have a psychotic person, I'm doing therapy with them, that's not appropriate treatment.
So if I'm hearing voices.
Well, you're not hearing voices,
Oh,
because if you're hearing voices, you're not actually hearing voices.
okay, help me understand that one.
Well, if
I'm
a
hear-
person comes in and tells me that they're hearing voices, they're obviously aware enough of the voices for them
Oh.
not to be a delusion. So if you tell me, if a person comes in and says, "Doctor, I have to be hospitalized, I'm hearing terrible voices to kill people," I know they're not hearing voices. Because when you're hearing a voice and I ask you if you're hearing a voice, you
I
say,
don't-
"Absolutely not.
Yeah.
I hear no voices," because they're hearing voices that they think are real. So they're psychotic. So by definition, you can't say I'm hearing voices and
Voices.
have voices. So you know that's not true. So if I tell you that, then the question comes up, if I tell you that that I'm suicidal, what is my risk? Your risk is actually higher if you deny suicide, right? So the standard question to ask, are you feeling suicidal, is, are you feeling suicidal? And someone says to you, no, not at all. Well, that tells you nothing. If they tell you,
Yes.
I am feeling suicidal, that's not telling you a lot, because if they really are going to commit suicide, they're not going to
They're
tell
not
you.
going to tell you.
So these are the things that you have to
hear,
contend
and
with.
again, through
There
television.
are safety assessments.
No, I'm just saying, through television, you hear that this person threatened to commit suicide as a cry for help.
Yes.
How much of it is real? Because it's a scary movie if somebody gets to a point
Yeah.
where
This
they're
is
not-
one of the things I think we really have to address in psychiatry. I think psychiatrists are very wary, and our field, particularly, I would say psychiatrists, social workers, psychologists are a little bit too afraid of dealing with the suicidal patient, and we immediately hospitalize those patients. In general, if a person is suicidal, putting them in a hospital puts them in a locked facility where they can't commit suicide, but they have to leave the hospital at some point, unless they're going to stay in the hospital and be in a state hospital forever.
Dr. Levine, if I put him in the hospital,
You're legally off the hook.
well, and more, I mean, ethically, everything you go, you say, "Whew, they can't kill themselves." And the good news for me personally is you can't come and sue me. But
Yeah, as the doctor.
As a doctor.
You're not the last, you want to be not the last person as a doctor to have touched the person before they did the bad
But on the other
thing.
hand, if I really go out on a limb and try and treat them and keep them their standard of living so they're home, and they do commit suicide, forget the legal, all that noise.
Yeah, you've lost a person.
I've
and
lost a patient.
It's horrible. It's a horrible thing. It's occurred
And
to
that
most.
little Hippocratic guy,
Yeah.
that little oath you took,
Do no harm.
do no harm. Boy, talk about feeling like,
But what is the harm done by hospitalizing someone who is your patient, who is saying to you, I have suicidal feelings. I feel sometimes that I don't want to live. I feel like I want, sometimes when I'm driving, to drive off the road. Well, how often do you have those? Now, there's a gut feeling in you that says, get in the hospital. But then you think about what's happening in the hospital to that person. What are they getting out of it? They're going to a new doctor who doesn't know them. They're going to a psychiatric ward where they feel like a stranger. They're already feeling alienated.
I was going to
usually
say, and all the
depressed. Why not come back
trauma
and
that
see me
comes with it.
tomorrow? Can you contract with me for one day? You know, could I see you tomorrow? I could do that. Do you feel? I know this person. I've been treating them a year. Now it's not, 3 minutes into treatment. 3 minutes into treatment, I'd send you to the hospital. Okay? But 3 years into treatment, and you're telling me I'm starting to have weird feelings like I don't want to live. I know you well enough to be the best judge of whether you really are. I've dealt with suicidal patients all my career, since day one. That's where you start training in the emergency room. And the things you see in the emergency room are always suicide. That's what you see. You see psychosis and suicide. You don't see anything else. People don't go to the emergency room for psychiatry unless they're suicidal or psychotic.
Jeff Hopkins is not going to get people to say, I'm just feeling blue today.
Yeah, you're going to be out of his emergency room and you're safe? Goodbye.
Goodbye.
Go see this nice psychologist, psychiatrist, whatever. But the point is, at the point where you're telling me, the psychiatrist, and I'm your doctor, that you feel suicidal, do I have to hospitalize you? And what is the risk benefit of that? Yes, there's a risk if I don't hospitalize, because I can put you in a locked prison.
And I can put you in a padded room and
make
the
sure you
quality
don't
of your
kill
life
yourself
just
for the
went-
next 10 days, but you're out of there in 10 days, and you've still got the same life to deal with.
Right.
Now, if it's true that you're going to go home that night and kill yourself, I'm going to put you in the hospital. But we shouldn't be putting people in hospitals. We wouldn't be sending them to the emergency rooms when we have any ability to manage them outside of the hospital setting. And we have to hold that liability as psychiatrists, social workers, and psychologists to be comfortable with managing suicidality outside
Again,
of the
you're back
hospital.
to do no harm.
Right.
So the question is, if you yank
Yes,
me
exactly.
out of my familial
Right.
setting,
Yep.
and you put me in an institution, I
Right.
mean, I don't care who you are, you're going to feel
Yeah.
a stigma.
Oh, yeah.
Something's wrong with me or I wouldn't be here.
And not just stigma, you're not going to be as well as with your family. You're not
Right.
going to be as healthy. I mean, your family is your primary, well, if it's a toxic family, I would remove you. But, if it's a supportive family who wants, and usually those families will say to me, I want to try to keep them home. I've done this so much that I can call a mother of, even a 40-year-old man who's I'm treating and say, or a wife and say, I'm going to break confidentiality here because it's a question of life or death, and I'd rather not hospitalize him. And, I get enough comfort from the
Then
wife.
you're back to do no harm.
Right, and those are these judgment calls that I just feel that if you're asking me from the beginning, how do I find and when do I know that I need to see someone, how do I know that I'm getting the proper treatment?
That's why it took you 14 years of study.
I don't know. I think it took me 25 years of experience.
Ah, okay.
I think I wasn't as comfortable when I first started. The word suicide, it was a knee-jerk reaction to hospitalize the person. And I think we're teaching psychiatrists and social workers very early on that that's the reaction.
Well, but also, you don't get a second chance.
Yeah,
At the end of the day,
yeah.
if
Yeah, and if you can't go to sleep at night as a physician thinking, I have a gut sense that I'm taking a chance here. I've told people this is a risk. You mom, you wife, sister, brother, family member, whoever it is who's going to be you definitely want to contact someone. And the person who is going to be your ally is in this process and say, are you comfortable considering that your patient, that my patient is suicidal, having them stay home with you, and they're comfortable with it and they want to try it, and you as a doctor feel like, I think there's a very realistic chance this person is not.
Well, but again,
You know, it's not a, it is more like it's a cry for help.
Most of the medical professionals can have a second chance. If you didn't do my knee right the first time, not
Yeah.
that it's pleasant, I get to come back and you get to figure out, you know, okay.
Because it's not your mind, it's your knee.
But
If I'm dealing with someone who's not in their right state of mind, they might lie to me. They could do anything.
Right.
And they might be not even knowing they're lying to me, you know.
and
So-
if they commit suicide while you left them home,
Right.
you can't come back next
So,
week
so
and say,
this
let's
becomes
try.
very much of a clinical judgment situation that really you have to be comfortable with. And there are definitely times I think we need to refrain from saying the word suicide means you go to the hospital. Because as you said before, there are many cries for help that are people expressing something else in their expressing feeling suicidal. And people feel suicidal
Right.
who don't commit suicide. Most suicides are committed approximately 1 month after someone has told someone about
Really?
suicide. They don't talk about it. There are two types of suicides. There's a planned suicide, which is never disclosed by the person. It's a well planned out event and they're not telling anyone about it. You're not going to see that person. You might have seen them 2 months ago. The second is an impulsive suicidal person. That's the one that's a little more scary because they do come close to the edge like 4 or 5 times before they actually act on it.
Step over.
And they step over. So the person in that situation says, well, how lethal were their attempts in the past? If they, jumped off a second-story balcony once and broke their leg, but didn't commit, they're pretty risky for the next. I'm feeling that feeling again.
If I jumped off the curb, probably not.
Or they thought about going out on the. So you're really dealing with a very thorough safety assessment, which hearing the word suicide isn't enough to do that.
And again, as every time you come on, fascinating. I think the take-home message I got is if I'm going to choose between a psychologist, I want somebody with 25 years experience.
Yeah, I think experience.
At the end of the
At
day,
the end of the day, in our field, experience is an awful lot. It's an
Yeah.
awful lot. And if the person has the wisdom that goes with that experience.
I want decades so that you can reach back.
One good thing about getting old in our field.
There you go. Thank you.
You're welcome.
And as always, I find this whole area fascinating. But I do want to thank our 6 loyal viewers for staying with us. The next few will be more technical when Dr. Levine comes on and we start talking about other areas. But as always, may God bless. May tomorrow be a better day than today. Thank you.
Not too long since I've been home. Been running all my life just